Hello friends, today we are going to discuss about the endometrial cancer. This lecture is the exam-oriented discussion for the undergraduate and the postgraduate students. What is the endometrial cancer? Endometrial cancer is the most common gynecological malignancy and it presents the fourth most common malignancy in the women in the UK, while in developing countries, cervical cancer is the most common malignancy. Endometrial cancer usually arises in the postmenopausal women. About 75% women present with the stage 1 disease, and for most of them, the management is surgical and the prognosis is very good. What are the risk factors? High level of estrogen or the endometrial hyperplasia, obesity, hypertension, diabetes, polycystic ovary syndrome, nulliparity, tamoxifen use or the breast cancer, postmenopausal women or the late menopause, heredity, non-polyposis, colorectal cancer. What are the symptoms? Patient may present with the postmenopausal bleeding, which is the most commonest presentation in the endometrial cancer, and up to 10% of these women will have a diagnosis confirmed. Watery and offensive bleeding or the purulent discharge due to the pyometra, shooting pain in the pelvic region if the tumor involved the pelvic region, difficulty and pain while urinating, ascites in the advanced stages, while the ascites is more common in the CEO ovary, abdominal lump due to the pyometra, fibroid, hepatomegaly, its less common features. What are the types of the endometrial cancer? Type 1. Type 1 are the estrogen dependent. Incidence of the type 1 about 90%. Premenopausal and the perimenopausal women involved. The causes of type 1 endometrial carcinoma is the endometrial hyperplasia. It's a minimum invasive, low grade endometrioid type and the good prognosis. While on the other hand, the type 2 endometrial cancer is the non-estrogen dependent. Incidence is around 10%. Usually postmenopausal women. Cause of the type 2 endometrial cancer atrophic endometrium, poorly differentiated, high grade serous or the killer cell tumors, and the type 2 having a poor prognosis. While the histological subtypes in the endometrial cancers are endometrioid adenocarcinoma, which is around 50 to 60%, adenosquamous 6 to 8%, serous papillary around 18%, sarcomas or the leiomyosarcomas around 3 to 5%, carcinosarcomas 2 to 3%, clear cell 1 to 6%. While discuss about the FIGO staging of the CA endometrium. So the stage 1, the CA endometrium when confined to the uterus, it is known as the stage 1. It is further divided into 1A and the 1B. In the 1A, the tumor limited to the endometrium or less than 50% myometrial invasion present, while in the 1B, greater than 50% myometrial invasion. In the stage 2, cervical stromal invasion but not beyond the uterus. In stage 3, pelvic involvement. Stage 3 further classified into the different subclasses. In the 3A, tumor invade the serosa or the adenexa. In 3B, vagina or the parametrial tissues involved. While in 3C1, the lymph node, which is the pelvic lymph node involvement, and in 3C2, the para-aortic lymph nodes involvement occur. In the stage 4, the bladder, bowel or the distant metastasis occur. It is further classified into the stage 4A, which is the tumor invasion, bladder or the bowel mucosa, and in the B, distant metastasis including the abdominal metastasis and the inguinal lymph node involvement. What are the 5-year survival? In the stage 1, if the patient present with stage 1 80 to 90%, in stage 2 60 to 70%, in stage 3 50 to 60%, in stage 4 10 to 20%. What are the prognostic factors of the endometrial cancer? depth of the myometrial invasion, histopathological type, original tumor volume, pelvic lymph node involvement, extension to the cervix, adnexal metastasis, positive peritoneal washings. Now let's discuss about the management of the CA endometrium. It depends on the history, focused history, and after that investigations. The history we already discussed, the patient present with the symptoms, and now the investigation including the examination, which is the per abdominal and per vaginal and the per rectal, preoperative workup, baseline investigation, specific investigations. Now the baseline investigations. For the baseline investigation, we go for the blood group with the Rh factor, full blood count, random blood sugar, urine DR, virology including the hepatitis B surface antigen, anti-HCV, HIV, and the COVID-19 PCR. Investigations including abdominopelvic ultrasound or the transvaginal sonography, renal function test, liver function test, chest x-ray, ECG, histopathology, high vaginal swab if needed, and the MRI. On the abdominopelvic ultrasound, what we want to see? Endometrial thickness, the cutoff value is about 4 mm. Endometrial myometrial junction, any pathology in the myometrium, uterine size, adnexa, urinary bladder or the ureter status. Now the stage-wise management of the C endometrium. In the stage 1, previously we discussed the stage 1 is confined to the uterus. If stage 1A, which is less than 50% myometrial invasion, the management include the total abdominal hysterectomy with the bilateral salpingo-oophorectomy. In the 1B, if more than 50% myometrial invasion, management including total abdominal hysterectomy, bilateral salpingo-oophorectomy, and the adjuvant radiotherapy. Adjuvant radiotherapy is given in the high-risk patients if the tumor present with the grade 3 deep myometrial invasion, cervical extension, or the serous or the clear cell histology present. While on the stage 2, when the tumor invades the cervical stroma, radical hysterectomy with bilateral salpingo-oophorectomy and the pelvic lymphadenectomy with the adjuvant radiotherapy. On stage 3, local or the regional spread of the tumor. In 3A, tumor invade the serosa or the adnexa. The treatment include the new adjuvant chemotherapy followed by the radical hysterectomy with lymphadenectomy, infracolic omenectomy, and the adjuvant radiotherapy. In 3B, vaginal or the parametrial involvement. The treatment including the chemoradiation. In 3C1, pelvic lymph node involvement, same chemoradiation. And in C2, when the para-aortic lymph nodes involvement, chemoradiation is the treatment of choice. In stage 4, the bladder, bowel or the distant metastasis present, chemoradiation. In stage 4A, when the tumor invasion is only the bladder or the bowel mucosa, and the stage B, distant metastasis including the abdominal metastasis or the lymph node, inguinal lymph node involvement. Now, what are the preventive measures? Controlling the obesity, blood pressure, diabetes to help to reduce the risk. Avoid the use of only estrogen after the menopause in the non-hysterectomized women. Estrogen, cyclical progesterone use as a HRT if needed. Report any abnormal vaginal bleeding or the discharge. Screening of high-risk women in the postmenopausal period. So this is all about the endometrial cancer. Thank you for watching. If you like my video, then please subscribe and share my video. Thank you.